Dr. Doug Smith, we do have two Dougs in the room, who is the Chief Medical Officer for Arch's Health Plans. You good?
Yeah, I think it's the right one. I just know that the front page is slightly different, so as I go through, I know I sent it. I just don't know when I changed it. So hopefully it's just the front page.
So Dr. Smith was born and raised in Salt Lake City. Following graduation from the University of Utah with a Bachelor of Science in Biology, he was fortunate to spend 5 years conducting medical research while attending the Medical College of Wisconsin in Milwaukee. Dr. Smith completed his medical training in 2006 from the Intermountain Healthcare McKay Family Medicine Residency in Ogden, where he worked closely with the indigent and minority populations of northern Utah. Following residency, he has been engaged in full-time practice with Intermountain Healthcare in the underserved and demographically diverse area of West Valley City. In 2010, he became board certified in hospice and palliative care medicine as an extension to his family medicine board certification. Other areas of significant relevant experience include rural emergency medicine, pediatric adult urgent care, and palliative care medicine. To better qualify himself to help affect change in our current system, Dr. Smith is pursuing further training through the joint ACPE and University of Massachusetts program for physician executive board certification.
Oh, that's old.
And oh, you're done with that?
I'm not going to do that.
Okay.
I'm going to do I'm going to do my MBA through BYU next year. So.
That's good. And why don't you start with that? Tell us some more about
So we'll have to
yourself.
change that. Yeah. Anyway, it's good to be here. Thank you. So we will see where we start. Arch's health plan. I guess that's where I should start. Most folks probably have not heard about Arch's, but hopefully our marketing firm will do a great job over the summer, and most people will have heard of us by the time the exchange is ready in October. So that is our goal. We've kind of wanted to be under the radar slightly, and now that plans and rates are submitted, I think it's time to reveal who we are. I guess I should go to the next one. What is a co-op, first of all? In the Affordable Care Act, there was a provision in Section 1322 that set aside money to fund a nonprofit, member-owned health insurance company in every state. Truly a co-op type model of health insurance. Initially there was about almost $7 billion set aside for that through different negotiations and fiscal cliffs and the like. That was pared down to approximately $2 billion, and there were 24 states who have a funded co-op health insurance company, and Utah is one of them. There are 2 in Oregon and 1 shared by Iowa and Nebraska. So on average, there's 1 per state in those 24 states. So how Arch's came about was through you'll see in our executive team a gentleman by the name of Sean Green, who is a West Point grad and Harvard MBA, working for eHealth Insurance, which is an online brokerage. With the new law, there were some changes in the way there were essentially 80 to 85% of all the premiums that came into health insurance companies were required to be spent on the patient care. And so there's what we call the MLR. And when basically the insurance company said, hey, we've got this 15 to 20% to work with overhead, and the brokers are making a big chunk of it, so we're going to squeeze the brokers. And eHealth was one of those, and so their revenues went down. And that, lucky for us, that Sean was the least tenured VP, and they cut his division, and so Sean was on the market looking for work. And as a good entrepreneur, he remembers reading the entire Affordable Care Act, and so he went and he remembered this section on co-ops, started calling around the country. Next thing he knew, the program directors in Washington called him, and he was in the process of putting a team together to develop this. And so 2 years later, here we are. I was involved about 2 years ago in April, and we put our executive team together and put together a business plan, and we put it forth to the Centers for Medicare and Medicaid Services, and they approved our business plan, and last July we were funded. So some of that information is here. We have a board of directors who is very community-centric. We have gone out and we feel it's our mission and to provide a cost-effective health insurance plan for all of Utahns, not just those that currently have it. And so there's well over 400,000 people in the state that don't have insurance at this time. So that's a significant portion of our state that needs an affordable option. And we feel it's part of our mission to fill that. And so part of this is our, we have a strong management team. Many people know a health plan called Public Employee Health Plan. When we were looking for a leader, there was a bunch of us guys that were sitting around table Normandy Cafe and talking one Sunday morning about who we would get to be our leader. And Brad Kuhnhausen, one of our founders, who is a longtime broker in the market, said, I know just the guy. So Lynn Baker was golfing and retired. He was the one that started Public Employee Health Plan. He went to the state, and the legislature in 1977 gave him the directive to do that. He built that company and then ran it until 2008 when he retired. And we went and dragged him off the golf course, and he's always been a believer in alignment of incentives and payment changes so that we can get better outcomes for patients and better costs for our patients and our system as a whole. And so Lynn came to lead us. You can see our folks here. Our most current addition will be Judy Hillman, who will be joining us as the VP of Engagement and Strategic Partnerships. She is a longtime advocate for the uninsured and I think all Utahns, and changing our delivery system to be more responsive to those in need. And Judy has been on our board. She will now join us as she will lead Utah Health Policy Project, which she was one of the founders of. She's done a lot of great work, so we're very excited to have her. That is a notable change. We're talking about Obamacare the other day, the ACA, and in our meeting, and we have a very diverse group. There's those of us on the right, there's those of us like Judy that are farther to the left, and there's those like Lynn in the middle. And so we're a whole big group of from politics one side to the other. And we were talking about the Affordable Care Act, and I said, well, look, the Affordable Care Act is kind of like a hamburger. There's good stuff in it. We got the good stuff. There's bad stuff in it. It may taste good, but may not be good for you. Kind of refined sugars in the, and you know, we've got a lot of sugar here, and that's pretty gross looking cheese. So I'm sure that's not good for you. So whether you're on the far right or the far left, there are points, I think, in the Affordable Care Act that we can say are good, some that are bad, and sometimes this looks like a nice burger, sometimes burgers are messy, okay? Whatever it is, it's the law, okay? It's the rules by which we have to live by, and so we're moving forward. We're not going to argue about the law anymore. It is the law. This was some of the proposed things that the healthcare reform was going to attack. The healthcare system, well, the reasons, you know, we can't afford what healthcare costs. You know, with an economy that's about $17 trillion a year, 2.8 trillion of that is healthcare and growing. Introduce disruption and competition. I think that's why we as a co-op are here. If we just put all the other incumbent health insurers into the exchanges, we just have the same thing. So we've been introduced, hopefully, to be some of that disruptive force and drive some change. And there's a goal to provide affordable options for the disadvantaged, and I put provide greater access to insurance, and hopefully, by extension, to care to the underserved. Insurance and care are different things, so hopefully that will lead ultimately to better care. The key changes, there's access issue obviously to insurance, and they've changed some of the rules. I mean, there's not going to be a rule where you go and say, oh, you've had diabetes, you can't get insurance. It's now what we call community rating. Instead of going to these small groups and saying you're going to be a healthy group, you're a sick group, you'll have high premiums, low premiums. Basically, they take different districts in the state and say the health is generally this in this area, and everyone's judged the same. So there won't be a judgment made based on your health conditions. So no pre-existing conditions, age-dependent care to age 26, and more support to the community health centers, which we think are a viable group of clinics here that provide very valuable services. Affordability, hopefully they'll be more affordable. I think we'll see health insurance rates go up. But there are some subsidies built into the Affordable Care Act. I'll show you at the very end of this that are fairly powerful motivators for people to get insured. And there's tax penalties, which are really at year one very small, grow over time. And basically, healthcare restructuring, there will be some essential benefits that insurance companies have to provide to be a qualified health plan that cover certain essential health benefits. The individual mandate, small stick this year, grows over the next 3-4 years to be more powerful. And so it will drive more people into the insurance market. Everyone is to be insured. And I don't know that we need to spend a lot of time on all of these. I know I'm going long, and so, but these will be on. Oh, okay, so let's just see if there's anything specific that we need to address. Let's go to the next, small employers. Really, when you look at the incentives in the Affordable Care Act for people that own businesses 50 and under that are actually providing insurance to their employees right now, really the incentives of this is to have them disband. I mean, if I were an employer that was offering insurance and I looked at it, I would look at it as more of a loophole for businesses 50 and under. With the exchanges and the subsidies, the money that will be there to subsidize people at different income levels are very powerful. And to be honest with you, I think that the small group market will change dramatically because of those incentives. And most likely will become more of an individual market in the future. And it will, I think, split more consumerism-driven individual and more large self-funded kind of large employer type plans. Federal tax credits for small businesses, but they're very difficult to get, to be perfectly honest with you. I think one of our founders was a broker. He went through these, tried to figure it out, and 1 out of 100 of his groups would actually qualify for those. So they aren't that easy to get. And we're working with brokers, and we'll have different access points for people to enroll. We support the local brokers when we go to groups. We don't want to disrupt that. We'll just work with their brokers. What businesses need to know? The important point, I think I'll go to the subsidy calculator at the very end. There's a very powerful graph there that will talk about the subsidies. But there's I think that's the main point here, is that there's going to be powerful motivators for people to be able to get individual insurance plans. For individuals, open enrollment, that's incorrect. The 15th, it will be October 1, but I would not be surprised if CMS pushes it back to the 15th or even to November 1st as they learn how to. This is a kind of a messy hamburger. I mean, it's not. They're having some difficulties implementing it. I think it'll be there. Mike Levitt said the exchange will be there, but it will not be a Formula One racer. They'll hope it looks like one, but it may function like a go-kart. So, however, it will be there. We believe that it will be there. They've tried to simplify some plans, so there will be platinum, gold, silver, bronze levels, depending on how much cost sharing there is to the individual that is purchasing it. For instance, bronze levels at 60% of the cost will be on the individual. all the way up to 90% for platinum. And the premium subsidy access full rate, okay. A little bit marketplace. So basically they're calling this the marketplace. It's basically like Orbitz, or I like kayak.com for my travel. And essentially it's a place where you'll be able to go and purchase online and compare plans to each other and purchase your plans online. And so much more consumer-driven focus of that. Talk about it'll give all the different premiums. We've been going through putting all of our plans into what they call HIOS and the SURF, which is a system that will put these up onto the exchange, and you'll be able to look at them and compare them. And it's a big quagmire, but I think we've gotten through it, so we're ready. So Arch's health plan, we have engaged Coventry, and the local plan is Altius. Is our friend and partner is right here. We are leasing their solution, so many of the things in which you just saw in our past presentation will be things that our members have access to with medical management. We will have access to the Coventry network statewide, and as well as the pharmacy benefits, and they will do all of our claims, billing, customer service, and all those type things. And so we see that as a good partnership here in the market. And one of the things we believe, ultimately we have a vision. Where are we going? In Arches, we believe in payment reform. We believe the incentive structure of money needs to change in the system to drive better costs and better care. And one of the things that we believe very wholeheartedly is that the initial focus needs to be focused on primary care and empowering primary care through whatever you like to call it. Medical home, primary care redesign, transformation, basically empowering the primary care to do a better job of quarterbacking and coordinating the care that is given to the patients. And working hand in hand with the specialty providers to provide specialty services when needed at the appropriate level as needed, but really to put that medical home and that primary care as the primary point where most folks get their care and build that long-term relationship. It can be very powerful. And Dean Health, I just watched a webinar today, a 3-hour webinar from Dean Health, who's integrated that through TransferMed, by the way, helped them initially with their consultation on how to redesign their primary care. And after about a 4 to 6 year period of time, they've been able to decrease their costs by 25%, at the same time driving vastly improved outcomes. And so better care at a lower cost by empowering and aligning primary care with value instead of volume. Instead of getting paid for every piecemeal thing you do, you get paid for better outcomes and ultimate end result of the care you provide. And so we believe wholeheartedly that that can be done. It's not easy, but it is doable. And so our mission is that we will do that. And we're working hard to build partnerships with primary care clinics at this time that will be able to help us deliver that. And that will change over time. This is that premium subsidy, and I think what is very powerful about this, and this is based on the UC Berkeley calculator, and what I like to show is if you use median income, which in the state of Utah I believe is about $55,000 a year, and I believe our family size is essentially about 3 to 4. Does anyone have it? It's about 4, so that'd be mom, dad, 2 kids, mom, single mom, 3 kids. If you go right over there and you go to 4, that is the maximum, the estimated maximum amount that somebody would pay monthly for their health insurance.
And how much is that?
For a silver plan, that's $351. So with the extra being covered by the subsidies. Whether you like the subsidies as a taxpayer or not, that isn't the question. They are going to occur, and they will be there in the exchange for all those plans that are in the exchange. So that is a very powerful motivator for people that haven't had insurance, that don't have it through their companies. And so we've built this, and this is basically with Medicaid expansion. This is 138% of federally poverty level, and this is the portion between 100 and 138. And so if the state were to expand Medicaid, then this would be all Medicaid, the gray. If they choose to not expand Medicaid, then there will be numbers that fill these TBDs.
I have a question.
Yes.
Back to that, we heard that earlier. Patty Connor spoke yesterday,
Uh-huh.
and she talked about those different coverages, and I'm still confused. Like, is silver coverage referred to where you fit economically, or is that a better way to
Silver,
say it?
so if you have a bronze plan, it's a 60% basic coverage. Silver is 70%, gold is 80%, platinum is 90%. So, for instance, that is the actuarial rating of the plan. So essentially, the estimate is that the individual would cover 20%, and the plan would cover 80% in a gold plan. So the cost of the premium, so a gold plan is going to be a more expensive premium than a silver plan.
But you get the same service, the same
Well, no,
coverage.
I mean, it's going to, an 80%, basically the patient will pay 20% of the costs, of the projected costs in a gold, 30% in a silver, 40% in a bronze. Okay, and a bronze plan will be cheaper, therefore. Why? Because the patient's going to have to cover more of the cost. Does that make sense? And so these are based on the second lowest silver plan in the state, whatever that ends up being. So you can make a guess that if these are based on, you know, that number that the 351, that's for a silver plan. If somebody decides to go and buy a bronze plan, it will be less than that. So, you know, and depending on how much subsidy they get, they could have a very low premium. And there's the potential of no premium, but, you know, we don't know that yet. And so it just depends on where pricing comes out for each plan. So that can be a very powerful thing to, you know, offer more affordable coverage to those that can't afford it right now. And hopefully be able to bring more people into the insurance market. So, I mean, I go out and talk to rural docs all the time that have a disproportionate amount of uninsureds, because who else is there? You know, it's local doc in Tremont, and he gets the patients because he's a good guy and he's got uninsureds that can't pay. And so, you know, you go to him and say, gosh, you know, if you get these people insured, we'll be able to pay you to do your work. And so now we won't have to do all this cost shifting in the market to try to cover the uninsureds and everything. And so I think it's going to be very interesting in 4 or 5 years to see what's happened. But boiled down, who are we? Arches Health Plan is a value-directed, driven, member-owned organization. We will be owned by our members when we have members. Currently composed of individuals from all sides of the political spectrum, committed and focused on what should be an apolitical issue, in our opinion. It should be apolitical. It is not, but it is. And working together to solve the problem of the way healthcare gets better. So thank you. Any questions? And then that's us.
And I do have one,
Yeah.
just to be clear. So individuals can purchase this as well as small businesses?
Yes.
Okay, either way.
Yes.
All right.
There will be 2 exchanges. There will be the federal exchange that is for individuals. That is the only place you will be able to actually access the subsidies that are provided through the federal government. There will be the shop exchange that is Avenue H, that HHS has told Governor Herbert that, yes, this year we'll let you do that. What is the future of that? We have our ideas, but we'll see. And we'll be, at this point, we plan to participate in that, so in both exchanges.
Is this plan going to
This is just a normal plan, just like any, you go to Altius, Select Health, Blue Cross, you'll go to Arches. We'll all compete in the same markets.
So Heidi, what may happen is, so COBRA is when, say, you lose your job.
Right, so it's a
You have
government plan.
You have up to 18, your employer has up to 18 months that they have to cover you, but it's at that premium, and usually it's fairly expensive. So
Yeah.
my understanding is COBRA would still exist.
Yeah.
But people might say, well, on COBRA, I'm gonna have to pay $10,000 a month, and based on my health, and I can go to the exchange and only pay $3,000.
If the exchange is open, right?
Right.
If,
Yeah.
and,
Somebody may decide to select individual plan
yeah.
versus continue with COBRA.
Okay,
And open enrollment is October 1 to, I think, March 31st. And so what happens after March 31st, probably a typical COBRA or however that works.
Yeah, you probably have to use your COBRA for a while.
Right.
oh, I see, okay, all right.
Does that
Well,
make
that's good.
sense?
Yeah, yeah.
Where did the other A go?
Well, oh yeah, that was in our infancy. So the double A came from Sean, our founder, came up with the name Arches. His kids play baseball at Skyline. He doesn't like Alta because of that. He thought, oh, we'll put Alta as our name. He was just thinking of getting us top rank order on any sort. And he said, but my kids would be mad at me if we made it Alta Health Plan. So, and it's a lot like Altius. So he said, well, Arches, but we want to be above Altius, so we're going to put 2 A's. And then we got a good marketing company, and they said, nah, drop the double A. So we are now Arches Health Plan. So this is truly an entrepreneur grassroots group that put together a company, and we're breaking into the market. So you had a question.
Yeah, you mentioned the open enrollment. My company, we just finished the open enrollment
Yes.
2 weeks ago. I was offered an opt-out of $2,000 a year. That's peanuts. Is this going to be the case like next year? Do you know? Is that something that's required by the Affordable Care Act?
So your company said you can opt out, and we'll put $2,000 in an HSA, or is that okay? So if your company offers you a health plan and you opt out, then you don't have access to the subsidies. You can go and buy a health plan on the exchange without a problem. You don't have to go to the, you can go to the exchange whether you get a subsidy or not. You can just go there and purchase it. If you're within the 100 to 400% of federal poverty level, you'll get some assistance to buy that plan. But if your company does offer you a health plan and you opt out, you don't get access to a subsidy, but you can buy your own plan. If they give you $2,000 in an HSA, then you could use that to buy insurance premiums, but that likely would not cover all of the cost. Now, if your company didn't offer you a health plan at all, you could then get access to the subsidies. And you could use that HSA to pay for the diminished premium if that fit. Does that make sense?
That does. The other part of my question I didn't get to yet, but you mentioned October to March. Is
That is
off the wall, or is that time slot that you would have? Because
so
ours is in late April
right.
to May.
Okay, so open enrollment for the exchange will be October 1 to March 31. And you would be able to go there and purchase a health plan during that period of time, whether you renewed in April or not. I mean, you obviously probably wouldn't want to be double covered and pay twice, but I guess you could if you wanted to. Did that answer your question? So. Now, our plans will not go active, though, till January 1. You can purchase them. I mean, you can say that you want that plan, sign up, and then January 1, it'll become live. We'll start paying claims to doctors. And so we don't go live October 1. We just start selling the plans. and then you'll start getting billed for them probably in December, coming up on January 1 start date. Does that make sense? So, okay.
I have a question on your little chart, the other.
Yeah.
What plan is that? Is it the gold?
That would be the silver. Second lowest, it's based on the second lowest silver plan.
Which means if I did this.
And we don't know what that is yet.
Okay, but it would be 30% I would pay or whatever you were suggesting. So
Right.
what's the portion that I pay?
Well, this would be this is the maximum amount of premium. So depending on your income and how many in your family,
Right.
this would be your maximum monthly premium. That's how much you pay a month for your health
The rest
insurance.
of the premium is subsidized.
Yeah, the rest of it is covered. Now, in the state of Utah, that's not a whole lot because we have fairly good health care costs here in the state. If you go to Massachusetts, it's outrageous. So,
But you said on the
So
silver
the
then,
70/30 is
yeah.
once you actually have the bill. So now
Right.
this is just paying your premium so you have coverage.
Right.
Now you actually go to see the doctor.
you still have,
Let's say the doctor's bill is $100. The plan would pay $70.
Yeah.
Okay, so on silver,
yes.
then I pay what percentage?
Yeah, so bronze is a 60-40 split.
And silver.
Silver, I mean, yes, so there's bronze, silver, gold, platinum. So it goes 60, 70,
Okay.
80, platinum's 90.
And so the premiums, of course, on each of the platinum.
They would change. Obviously, a platinum, if you wanted to go and get a platinum, it would be the opposite of the bronze. The bronze, you'd get lower numbers. Platinum, you'd get higher numbers if you wanted to get a richer plan. So, but it would make a platinum plan more affordable. So,
Okay, cool, thanks.
yep.
It's interesting to see the subsidy chart. It looks like it maxes out at $155,000.
Yeah, if you have a whole load of kids. Yeah, like our COO, our founder, he has 8 kids, so there's 10 of them. So you could even take it out further. And I can't remember, Sam, do you remember how much Sean could make and still get like $1 worth of subsidy a month? We figured it out to the dollar, but it was pretty high.